So for the last couple of years, I've run into a little trend I've noticed in at the FMMA meetings. There was most of you know that the direct primary care world is reasonably well established. There's some good roadmaps. Phil has some great resources for helping people get started on that. But one of the things I noticed when I would come to meetings was that there are a bunch of surgeons in particular and other specialists, but mainly surgeons. I'm a surgeon, so I talk to other surgeons who are wondering, well, how the heck do I do this? And so when I was talking to the organizers last year, well, actually the year before that, they said, well, would you like to do something? And so I collaborated with Dan Paul and George Azude, who's there in the back, and we did a panel discussion kind of introducing some of these concepts. And they said, would you go into a little more detail about that this year? I said, sure, I'd be happy to do that. So while a lot of these principles apply to any kind of physician, our main focus here is going to be on specialty physicians, okay? Because the model for specialty care, as you know, is different than the model for primary care. There's some overlap and some exceptions, but for the most part, we have to approach them differently. And so I can't, in the course of half an hour, show you every little nut and bolt on how to do this. So what I'm going to do is introduce general principles. And then, if you're interested in having a more in-depth discussion, I'm happy to do that. I'm here for the next 2 days. And there are other people in this room. Again, George is a great example. I'm going to reference you a couple times, George, on really innovative ways to crack this nut. Okay? So let me start by saying this. What if I told you, and probably some of you, who in this room is here because you heard that I was going to talk about bankruptcy? Okay, all right. So what if I told you that direct care saved me and my practice and my family from bankruptcy? I went from, and I'll keep this part really brief, but just to give you context, okay? All of this, everything I'm going to tell you about today comes from the hard lessons that I learned from doing things the wrong way until all I had left to do was to do it the right way, okay? And the other thing I want you to take away from this is that I suck as a businessman, okay? Ty, you've heard me say that before, right? I suck as a businessman. I thought I was really good at it until I actually had to do it, okay? This model works not because of me, but despite me, okay? And so if it can work for me, I'm pretty confident it could work for you, okay? So let's get into this. Let's talk about the new rules for direct care success. There are 4 things that I want to cover with all of you today, okay? Number 1, and we'll go into these in a little bit more depth here. Lean operations. That's the first thing you got to keep in mind. You want things to be lean, okay? Number 2, know your strengths and know your niche. You might know your strengths, but you may never have thought about what your niche is. And we'll go into that a little bit more, okay? Number 3, this is the one that I get asked about all the time. You have to be able to determine your value. You the doctor, okay? And then number 4, contrary to what you may have been told in medical school or in residency, marketing is not a dirty word, okay? It's got more than 4 letters in it, so... All right, so let's talk about lean operations. What do I mean by that? Now, you've heard, you've heard that in real estate, what are the 3 key words in real estate? Yeah, location, 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 right? We're gonna get into the 3 key words when it comes to starting and running a successful direct specialty care practice. Okay. First of all, throw away the box. Okay, don't just think outside the box. You got to throw away the box. And I'll go into that a little bit more here, okay? The 3 words for a direct specialty care practice are overhead, overhead, overhead. Okay? Anybody that's ever run a convenience store understands this. Overhead is your enemy. Anything and everything you can do to eliminate overhead will be your friend. Again, assuming you're not breaking the law, reference Phil's talk, okay? All right? Assumptions. We all make them. Most of us don't even realize that we're doing that. So you gotta root out those assumptions. You gotta figure out, what am I assuming? And most of the mistakes that you're gonna see me talk about are all based on assumptions that I made that I didn't even know I had made. Most of us have spent most of our lives being brainwashed by the insurance industry to believe that certain things have to be done a certain way. And when you really take a close look at why you're doing X, Y, or Z, ultimately your answer is probably, well, that's the way I was taught to do it. Or that's the way I've always done it. Those are never good answers. Chase it down until you figure out what the answer is. And if that's the answer, then you know you need to take a close look at how you want to change that. Okay? Assumptions that you make, your EMR. Okay? How many here are already doing direct care? Okay. So there are a number of you that aren't. And am I correct that you're here because you want to try to figure out how? Is that a fair statement? Okay. So your EMR. Dan Paul, who's one of my heroes, he's an orthopedic surgeon in Colorado. His EMR is Microsoft Word. Okay? We'll go into that in a little bit. George, what do you use?
I use eClinicalWorks, and that's just so I can prescribe narcotics.
Exactly.
Otherwise, I wouldn't have it.
Okay? Most of the mechanisms built into your EMR are built for coding and billing. If you're doing direct care, you're not doing any billing. We'll go into the coding in a little bit. If you're not doing any billing, do you need to pay for all of that stuff that you're not actually going to use? That's an important question. Okay? Staffing. Staffing. You think you need a nurse. You think you need a receptionist. You think you need a billing manager. You think you need all these different things. Ask yourself whether or not you really do. Okay? Who do you pay and how many of them do you pay to do prior authorizations? Are you going to do prior authorizations anymore? Okay? CPT and E&M codes. We're going to dig into that a little bit more. Okay? And then again, billing. Are you going to do billing? I mean, if you're in a direct care practice, that looks very different. In my practice, the billing happens usually before the patient even walks in the door. Okay? A lot of my patients pay for the services before they show up for their appointment. And then they pay for surgery before the date of surgery. Who deals with denials and appeals? Do you need staff to do that any longer? Do you need to pay a billing company to deal with that any longer? Oh yeah, sure, they tell you, oh, it's only 3%, it's only 5%, but what about all the time and energy that you spent working on that stuff that you could have spent taking care of patients or getting the word out about how awesome your business model is? Okay? And then office space. We're gonna go into that in a little bit more. Okay? Again, I like to think of myself, I used to think of myself as pretty innovative until I met Dan Paul, who started his orthopedic practice out of his car. Okay? He didn't have an office. He would go do house calls. You see patients face to face at their home, their work, their place of work. He'd see them at the Walmart parking lot. Most of his patients were uninsured and they were happy to pay his fees because they knew exactly what they were going to be in advance. So what was his overhead? His malpractice, insurance on his car, and gasoline. Oh, and he had to buy a portable x-ray machine. Okay? That's a lot different than the thousands of dollars a month you're spending on that big fancy office space. Okay? Lean operations. In 2018, when I opened my practice, I had 9 employees and 3 contractors. Today, I have 3 employees and 1 contractor. Did I need all of those people? Turns out I didn't. And we'll go into that a little bit more. But it took me that many years to figure out I had way too many people. I had too much overhead. Okay? My EMR in 2018 was $1,700 a month for a whole bunch of capabilities that I didn't use, that I thought I might use, that turns out I never ever needed. Now I pay $300 a month. My office in 2018, 2,900 square feet for me. Okay? Today, it's 1,700 square feet for me, and actually next month we're moving into a bigger office space. You're like, wait a minute, didn't you say you want to go smaller? Yeah, for 2.5 of us. Because not every single person needs to be, I mean, utilization is terrible when you're a single practitioner and you got all this space. You're like, well, I can't be in 3 exam rooms at once. Why do I need 3 exam rooms? And if I have 2 exam rooms, can I have somebody else using that other exam room? Or maybe 2 different people or 2.5 people using those exam rooms at different times? When I'm in the operating room, what happens to my exam room? It gathers dust. and it costs me money. So I found a couple people who are interested in using my exam rooms when I'm not in them. Okay. For what? That office space for the 2,700 square feet in the Omaha area, I think we're paying about $3,500 a month. Well, we will be anyway, starting next month. Okay, know your strengths and your niche. What do we mean by that? Okay, this is the key question. This is one of the questions that doctors have the hardest time answering honestly. Okay, what do you do better than anyone else? Now, why do I say doctors have a hard time answering this honestly? Because we as physicians limit ourselves. Because when somebody asks you, what do you do better than anybody else? Well, I start to think to myself, well, I do a carpal tunnel release better than anyone else. Or I do surgery for postherpetic neuralgia better than anyone else. But what I do is not just limited to the surgical procedures that I perform. Okay? What do you do better than anyone else? Is it the time that you spend with your patients? Do you do that better than anybody else does? Is it the outcomes that you get? Do you get better outcomes than your colleagues? That, as a surgeon, we're accustomed to thinking that way, but we don't think about time. Okay? Is it the patient experience? Is it the whole package? Is that what you do better than anyone else? You have to be able to ask these questions and look yourself in the mirror honestly and say, okay, where am I better than everybody else? It's not just about cost. It's not just, oh, well, I can do this cheaper than anybody else. Okay? It's about value. All right? And what is value? Value equals quality divided by cost. What kind of value proposition does your patient want? They want the highest quality at the lowest cost. But they can't determine value if they don't have both pieces of information. And this is one of the things we do in our practice really, really well. When patients come and they say, well, I'm going to go see so-and-so because he's in network. Okay, good, you do that. We want you to get a second opinion. When you go there, ask Dr. So-and-so to give you in writing a guarantee of what this is going to cost. Because that's what you're going to get when you walk out of my office. In writing, down to the last penny, guaranteed, you will not get another bill. This is exactly what you're going to pay, no more. You have my word and you have it in writing. They can't provide it. And so what ends up happening, those patients that walk away, we track these numbers, 85% of them within 12 months are back at our office. They will come back. Okay? It's not like a car dealership where they got to get you when you walk in there the first time, otherwise you're going to go buy it somewhere else. That's not the way it works if you're offering real value. Okay, now, speaking of value, how do you determine your value? All right? Or the way I get asked this question all the time, well, how do I know how much to charge? I don't know, you could do it the way Medicare does, just put up a dartboard and throw a dart at it. You know, that's how much they decide they're going to pay you, right? You know? What if I told you that's the wrong question? How much do I charge? Okay, that's the end result of having answered the correct question. Okay? The answer, just like when you go to your oral exams for your board exam, well, it depends, right? But I'm going to dig into that a little bit. Okay? So there's a few different ways you can do this. You can use reference-based pricing. How many here are familiar with reference-based pricing? Okay, for those of you that aren't, reference-based pricing means simply that you take some reference point. Commonly, people will use the Medicare allowable for their area for a particular CPT code or E&M code, and then they'll use some multiplier of that. And they say, okay, I'm going to charge 1.2 times Medicare, or I'm going to charge 2.3 times Medicare, or I'm going to charge 11 times Medicare, whatever it is that you decide that number's going to be. Now, that has the advantage of being something with which you're at least passingly familiar. Okay, this is something you're comfortable with. You can also charge fair market value. Well, what's everybody else charging? Okay, there are ways to find that information out. Dean Jargo, is Dean here in the room right now? No, I don't see him. If you find him, he's got a number of resources available to him to help you figure out what fair market value is in your area. The challenge with that is that until these resources became available very recently, it was really hard to figure out what's everybody charging in the area. Okay? Because as we know, the insurance companies don't want you to know that stuff. They don't want anybody to know that stuff, okay? But what if I told you there's another alternative? And this one, I'm told, is rather, it's rather radical. What about hourly? What? Hourly? What do you think I am? Some kind of plumber? You know, or some person working at a gas station? I get paid hourly? This was brought up to me by a friend of mine who's an attorney. We work on a few cases together from time to time. He said, Doc, I don't understand all this CPT and E&M code business. So I spent 20 minutes explaining to him. I said, do you get it now? He goes, well, I understand the mechanics. I understand the how. I don't get the why. Why do you charge, why do you use these CPT codes? Well, I said, that's how we determine, what we're worth. He said, really? He said, so you're telling me that code tells me what something is worth? Well, yeah. So if doctor number one, who does 1,000 total knees a year and has 0 wound infections, uses that code for the total knee, and doctor number two, who does 10 total knees a year and has 50% of them with wound infections and 1 revision for each of those 10 a year, uses the same CPT code, you're telling me those are equivalent services and should be paid the same. Who here agrees that that would be the case? I don't see any hand. Oh, maybe one. So the person who does great work should be paid the same amount as the person who does crappy work.
Oh, that's the way it is.
That is the way it is now. But would anybody here agree that that's okay? That's my question. Okay. And yet, a lot of people want to push for that. It should be the same price for every doctor. I disagree. Okay. And so did my attorney friend. He said, look, some attorney, the senior partner in the practice, he gets paid a lot more than the junior associate who just graduated from law school. And rightly so. Okay. He said, I have an attorney. I pay him an hourly rate. I have an accountant. I pay him an hourly rate. Why don't you guys get paid an hourly rate? And I was like, it's a common answer that medical students give, right? Right? Okay. Ultimately, what will the market support? You're figuring out your hourly rate, and we can go into the mechanics of that. But ultimately, these are great starting points. Okay. And ultimately, the market will determine, if you're doing true free market medicine, what your pricing should be. Okay? Plan, whatever one of these schemes you use to determine your pricing, expect that whatever number you come up with first is wrong. Plan on that. Okay? You're going to use reference-based pricing. You're going to use, fair market value. You're going to use an hourly rate. Whatever it is, just know that it's wrong when you start. Try it for 6 months and see what happens. If you try it for 6 months and you have a 24-month waiting list, what does that tell you about your pricing? It's too low. Try it for 6 months and you have nobody coming in the door, you're making one of 2 mistakes. Either the word isn't getting out or your pricing is too high. And then adjust. Okay? Marketing is not a dirty word. Okay? We've been told that it is, right? As physicians, you heard this from your attendings, you heard this when you were doing your fellowship, you heard this when you were in medical school. Marketing is a dirty word. And nobody reputable in medicine does it, right? Well, make no mistake, it's being done in specialty medicine by people who are very reputable. All right? Think about cosmetic surgery. Now, some of you may think, well, I'm not sure those cosmetic surgeons are all that reputable. Okay? I mean, I used to do a lot of cosmetic surgery. I don't anymore because there's other stuff that I find that is more satisfying for me. But cosmetic surgeons have been doing this for decades, and they're really good at it. Okay? What about LASIK surgeons? LASIK surgeons have been doing marketing, and they're really good at that too, right? There's a lot of price transparency. You'll see these billboards. Oh yeah, 2-for-1 deal this month. Get both eyes for the price of one. Okay? Dental implants. There's a lot of marketing that goes into dental implants. And I've seen some people with really, really nice dental implants. Okay? Dermatology, a lot of dermatologists out there doing a lot of marketing. Okay? It's being done. It's been done. There are people who have been doing this for decades who are really good at it. That means you could do it too. All right? Hormone therapy. How many of these testosterone clinics have you seen all over the place? Okay, that's all marketing, right? So, number one, you got to know your audience. Are you taking care of 20-something-year-old females? Are you taking care of 80-year-old males? Because your audience will tell you which avenues will suit your marketing the best, okay? This is also a function of knowing your value. You got to know what you're worth so that you can get that message out to everybody else, okay? Don't be afraid to teach, okay? How many of you here know Phil Boucher or know of him, okay? So he's a pediatrician, direct care pediatrician in the Lincoln, Nebraska area. If you're not already following him, I highly recommend that you do. Find him on LinkedIn. He has some great little clips. He puts them out multiple times a day. I don't know how he has time to do this, but he has great little clips on figuring out how to show your value to your potential patients. And the key is potential, okay? He talks about teaching, and I think he's right. Your marketing should be primarily aimed at educating rather than selling. We talked about this earlier. Who was here for the chapter leader meeting? Okay, what was the key message? Don't pitch, right? You come in and you give a pitch, all of a sudden you're a salesperson. You're not a physician anymore. Okay, educate. The word doctor comes from the Latin word docere, which means to teach. Our first duty is to teach. So let's teach. Use whatever marketing you're going to do to teach so that the selling becomes a side benefit. You become the subject matter expert when the patient doesn't need you, so that when they finally do need you, you're the one they trust. You're the one they're going to go to first. Okay? Establish the trust before you even see the patient. Establish your credibility in the eyes of the patient as an educator. And then they'll naturally gravitate toward you when the need arises. Okay? So what kind of strategies can we use? Direct to consumer. Okay? And of course you're thinking to yourself, okay, so I'll market to my patients. But your patients aren't your only consumers. If you're going to be doing direct care with direct contracting, your employers are your consumers also. So you have to know how to speak employer. This is something that I've spent the last 8 years trying to learn, okay? If you can get buddy-buddy with somebody who's a benefits advisor like Ty, okay, or a TPA or a broker, then you can learn to speak employer also, okay? So that you can have intelligent conversations with them, or if you're putting this out through your marketing channels, you can put out stuff in language they can understand. Just like when you're talking to your patients, okay? You're not gonna talk to your patient who's a mechanic the same way you're gonna talk to your patient who's a radiation oncologist. Speak the language that they know, okay? The other strategy is direct to your referral base, right? And of course, you're thinking to yourself, well, that's a bunch of other doctors, right? And that's true. Although you will find as you transition from your conventional model, okay, I don't like to use the word traditional because traditional medicine is actually direct care, okay? How many of you knew that? The direct care is not a new idea. For thousands of years, direct care is the way medicine was practiced all around the world and is still practiced today in many countries. It was only in the last 50 or 60 years that insurance has taken over here in the United States, okay? Don't let anybody tell you, oh, this is a radical new idea. It's not a new idea. We just threw away the good idea, okay? Your referral base can be other clinicians, but don't forget the power of family members. I can't tell you how many patients I've had who have come to see me, not because they wanted to see me, but because their wife, their husband, their brother, their sister, their mom, their dad, their son said, you need to see this guy. You've been complaining about this for years and years and years. This is the guy you need to see. Reach out to the family members. Talk to them about what they're suffering as a result of disease X, Y, or Z. And what they see their beloved their loved ones suffering as a result, okay? So let's talk about pitfalls. Any questions so far? I told you the to-dos. Let's talk about the don'ts, right? Okay, so when it comes to lean operations, I'm a surgeon, right? Don't be afraid to cut. It's easy for me to cut tissue. It's a whole lot easier for me to cut staff. But this is something we have to get accustomed to, okay? As physicians, We know how to cut. Okay, cut out the saturated fats. Cut out all the excess sugar. Cut out all the screen time. Cut out whatever it is that needs to be cut out in order for you to get better. We have to be able to take that same attitude into everything we do with regards to our practice. Okay, don't be afraid to cut. Sometimes you have to amputate in order to save the patient's life. And sometimes you have to amputate in order to save your practice's life and your family's life. Okay, in a direct care practice, this is really important. I cannot emphasize enough how I made this mistake, okay? In a direct care practice, a fancy office and lots of staff means more money out of the patient's pocket, okay? How many of us have gone into a doctor's office or gone into a hospital and said, wow, this is really cool. Look at all the fancy painting and vaulted ceilings, fancy furniture. And you're like, whoa, this is really nice. They got a coffee machine. Why do we think that's okay? Because we don't feel the pain of paying for it in the moment. There's that delayed payment if we're using insurance. But when that patient comes to you and has to pay the day of the service, they look at that fancy office very differently, okay? Don't think they don't notice. If I parked my Ferrari, which is called a Mazda, okay? If I parked my Ferrari right in front of my office, okay? Is that patient gonna think, oh, this guy's really good? Or is that patient gonna think, I think I'm overpaying this guy? The patient doesn't care if the office is fancy, if they're the one paying the bill. What they care about is whether or not you get good results. Okay? So don't skimp. Be prudent about what your office is like. If you're if you're in a solo practice, you probably don't need a 20,000 square foot office. Figure out what you do need, cut out the rest. Okay? Know your strengths and your niche, okay? There is no room for false humility when it comes to determining your strengths and your niche. Be brutally honest with yourself. Don't be afraid to say, you know what, I'm not as good at this as so-and-so is down the street, but I am better at this. Nobody does this better than I do. Okay? Determine your value. What's the single biggest mistake that physicians make when they're trying to determine their value? They undervalue themselves. They say, I'm not worth that much. I don't want, they're afraid that the patient is going to be scared away by numbers. If you keep your overhead low, you can afford to charge lower prices that still reflect your value because you don't have as much overhead to pay for, okay? Two things here to keep in mind. Number one, and we talked about this before, if you're charging too little, nobody is going to take you seriously. If you're charging $50 for a total hip replacement, they're going to say, did you get your degree on eBay? Where did you do did you do a residency? Charge too much, nobody's going to show up. Okay? And then here, big mistake I made. I can't tell you how big this mistake was. Okay? Out of network billing. So I was ready to do pure direct care when I left the FMMA meeting in 2017. And then I met with a buddy of mine who's another peripheral nerve surgeon, and he said, oh yeah, he said, I do that too. He goes, but I try to be nice to my patients as though direct care isn't nice, right? I try to be nice to my patients by doing courtesy billing for them. So what does that mean? He said, well, I don't have any network contracts, so I just submit an out-of-network bill on behalf of the patient. The patient pays me up front, and then I reimburse them whatever it is that the insurance company pays me. I said, oh, that sounds good. He goes, yeah, because then the patient, I get paid, and then the patient realizes the insurance company's a bad guy. You know what I discovered? The patient doesn't think that the insurance company is the bad guy if they're waiting for you to get money from the insurance company. They think you're doubly bad because you paid them, or they paid you, and they're expecting a refund because they think their insurance company is going to pay 100%, and when they don't get that 100%, they're pissed off. Are they pissed off at the insurance company? No, they're pissed off at you, okay? My advice to you is that, and this has been my personal experience, anytime I have any kind of interaction with the insurance company and the patient knows that I have that interaction, I'm the bad guy when it doesn't go well. Because I'm supposed to fix it all. Because that's what doctors do, right? We fix stuff. Well, if I didn't fix that, then clearly I'm the one at fault. And the insurance company will tell them, oh, well, your doctor didn't do this and your doctor didn't do that, or your doctor filled this form out incorrectly and did this other thing wrong. It's much safer if I don't have any interaction with the insurance company because I don't have a contract with the insurance company. I have no relationship with that insurance company. Who does? The patient. I'm like, that's your contract with the insurance company. What happens all of a sudden? The patient then realizes, oh, that denial wasn't the doctor's fault. It's the insurance company's fault. And then they come back to you and say, now I understand why you don't do that. Marketing pitfalls, okay? You can use print materials. You can use billboards, you can use radio or TV advertising, you can do vehicle wraps. I do that. I have 3 vehicles that are wrapped for my practice, mine, my daughter's, and one of the people in my practice, okay? We can talk about that more if you like, okay? Door to door and shaking hands. There's nothing more effective than a face-to-face interaction, okay? My personal experience with each of these, print materials, we tried it. We didn't see any return on the investment. Billboards, we tried that, we got a little bit, but the monthly fees were expensive, which is why we switched to vehicle wraps, because then you just pay the one-time fee, which is about the same as a billboard, and then that car's going all over the place. Every time I stop to get gas, people ask me about my practice. Radio and TV advertising, I didn't really get anything out of that either, okay? Social media. 56% of my patients come to me through YouTube. Another 38% find us primarily through Facebook, okay? About 20% are referrals from previous patients or family members. Less than 3% of my patients come from other physicians, physical therapists. I get more referrals from chiropractors than I do from all the physicians, NPs, and PAs put together. Because chiropractors understand direct care. Chiropractic care has been direct care for like forever. So they get it. And they want to support other people who are doing direct care. Earned media. Who here knows what earned media is? Okay, earned media is media you don't pay for. When you've made a big enough splash that the media is coming to you instead of you having to go knock on their door, that's free advertising. Okay, my practice was on NBC Nightly News, CBS This Morning, and CNN's Champions for Change. That was earned media. Because they saw some of the stuff we were doing and they're like, this is a good story. Let's talk about this. When you reach that point, you know you've gotten people's attention. You know that your marketing is effective. You know that the care you're providing is valuable. You know that you are offering value when the media comes knocking on your door to share your story. Okay? So to wrap up briefly, the 4 rules. Number 1, lean operations. Number 2, know your strengths and your niche. Number 3, determine your value. And if anybody's interested in hearing how I did that, I'm happy to do that. Okay, and then marketing is not a dirty word. What questions do you have?
How do you work with the brokers that are out there building plans?
Okay, so for those that didn't hear the question, how do you work with brokers or other facilitators who are working with high-performing employers who are trying to develop high-performing plans? So number 1, you got to find somebody that's on your side, right? And sometimes that can be hard to do, finding somebody who's interested in doing direct contracting, okay? Once you find that person, what you'll discover is that they've actually been looking for you. They just didn't know you existed. Okay? And once you find one, then you find that person knows a few others, and then they connect you to a whole bunch of other people. That's how we ended up with success at our first Nebraska FMMA conference. I thought we were going to get 20 or 30 people to show up. We had over 100 at our very first event because we had a couple of enthusiastic people, passionate people in each of these different sectors who knew other people, who knew other people, who knew other people. It's a snowball effect. You find a couple key players, and then they tell other people who tell other people who tell other people. Does that answer your question? You're welcome. Yes?
How did you find your...
How did I find my value? Okay, I love when people ask this question because, you know, the reason I did it this way was because when I was trying to calculate what I should charge a patient for a particular surgery, it was really hard. It was time consuming. Sometimes it would take over an hour because some of the procedures that I do may have 40 CPT codes. I was like, well, how the heck are we going to do that? And then we got to figure out the, the multiple procedure discount. Are we going to offer a multiple procedure discount, et cetera, et cetera. So my attorney said, all you got to do is take what you think you need in terms of gross revenue and divide it by 2,000. I said, well, why 2,000? He said, well, most people, not you, but most people work for a 40-hour work week, and they take 2 weeks of vacation a year. So that's 50 weeks a year, 40 hours a week. What is that number? 2,000. So you take your gross revenue that you're looking for, divide by 2,000, there's your hourly rate. Now, can I tell a patient, oh, well, we're going to charge you, we're going to charge you this much an hour for you to come see me in the office? That's not intuitive to the patient, right? The reality is, what is a patient looking for from me? They're looking for two things: my expertise multiplied by my time. That's it. Okay, whatever kind of expertise it is, however I apply that, what they're really looking for is my expertise multiplied by my time. And so what we decided to do instead was take that baseline number, divide it in half, that's my hourly rate in the office, and then we double it for my time in the operating room. And that, to the patients, is intuitive. The math works out, over the course of a year, and everybody's happy. Now, if you'd like, I can go into a little bit more detail. Who read this? Okay. I didn't see any reactions on your faces. Like, you must just be getting ready, getting hungry. So I'll try to go through this last part. I figured there might be some people that wouldn't have questions, but I want to share a couple other things with you. Okay, so we talked about how I screwed things up, right? And how eventually I had no choice but to get better. Okay, 2021 was when we hit rock bottom.